Sanbonan colleagues, I think we can start the session. Cyprian will find us on the way, and if he's still not making it, we will proceed with the case and discuss on it and learn from it. So my name is Sandile Mahlangu. I think many of you have missed my face on the screen, but today I'm great. I'm with you. Maybe we can introduce ourselves on chat by writing our names and where we are coming from. And also introduce ourselves by saying who we are joining with. Let me emphasize that it's very critical that when you are joining with someone else, that person, if registered, you need to join with him even on the joining session so that the attendance register will be able to capture that person. So when it comes to qualification for attendance and attendance certificate, he will or she will be able to qualify for the certificate. Thank you so much. I can see Tandazile from Manzini Government Hospital. Your name is Sam Numalo. Maybe for these 5 minutes, can I give you the opportunity to share your reflections from the previous sessions that we have had and what we have learned so far in these sessions while I'm preparing to share on today's case presentation. Let me open this. You will greet us and share your experience so far, what we have experienced. Anyone who wants to share for this long way we've gone? I don't know if someone wants to share something with us. Let me start with Zihle, the RFM palliative care team, the ever strong team. I can see Zihle is within Tuli there. Good people who are doing a great job with RFM. I don't know, do you have something to share with us so far on how far we've gone in these sessions? If anyone wants to share, Zihle, do you have something to share? We are left with one session actually to round up this pain module. So I don't know if anyone to say not for today. Okay, I get it. But you need to say so we can know everyone is audible. Ziggy, you also don't want to say anything today. Yeah, just share whatever that you think you have captured from this module. As we are closing, Tandazile and your team, is there anything you can wish to share so far from what we have covered in the previous sessions? While I'm still preparing to share our case. Okay, Tandazile says we'll write in chat. We will appreciate that one. It will help us to know how far we've gone. And also, we have Simpiwe. How are you, Simpiwe?
Yes, I'm okay. I'm okay. Thank you.
Thank you so much. Do you have to share something that you have learned so far?
Thank you. What I have picked is that we need to think outside the box. Especially, it's still on my mind is that other case that we discussed, which was taking care of the client towards the end of life, where we needed to not only focus on physical pain, but also emotional pain and the end of life. Our clients' emotions, where they what they go through, that we need to also understand that whatever resistance or whatever the difficulty they are going through, it also translates into accepting the interventions that we try to bring to those our clients, which when we have such insights from such presentations and platforms of learning and capacitating each other, it helps us to understand and give the care that is appropriate for that situation, especially all the facets that we need to tap on. Thank you.
Thank you so much, Mr. Jamin, for sharing such an insight. Yeah, indeed, it's a learning experience, it's a learning curve. We are learning new things, you know, the traditional way. We are confronting it with this model of palliative care, that we can do something to manage our patient, and our care is beyond the pharmacology that we may have in the facilities from the pharmacy, but it goes beyond that one. We need to also cater the psychosocial, spiritual part of our clients. Mhlanga Nompumelelo, do you have something for us that you may share? Hello, Nompumelelo. Oh, okay. I think Nompumelelo, can you hear me, Nompumelelo? You know, today I have a network challenge here, so I'm not sure if she can get me. Mr. Pongwayo, do you have something to share with the team from our experiences in the previous sessions? I don't know if people are here or they left, but so for today we are trying to do a bonus on our session okay. We are trying to look around on a bonus what Diana presented on last time. While actually now what we are doing, we are moving closer to finishing this module on pain so that we can open the other one on symptom control, and then we'll be finishing our physical domain in pain management, or in pain and symptom management under palliative care. So we are covering. We are hoping we will finish this year with 1 or 2 sessions under physical, and then we start next year rounded series. I will appreciate that we continue as a team like this as we unpack the different coming series too. May I show present on today's session? It's just a reminder, and it's a recap on what we learned in our last session. So it won't be that much in detail, but I will be picking those critical areas that Diana touched in another way and present another system that we can use to deal with pain. Especially today, we'll be repeating the neuropathic pain, the breakthrough pain, because that's one of the challenging types of pain we face, and that's one type of pain that is under managed. So I will see how best we can manage it. You know, today I have a little bit of matata here. Please bear with me as I'm trying to show the slide of our presentation. So I'm hoping today we will be able to pick it up and be able to summarize a little bit of this pain. So otherwise it will be more of a discussion today. So I will request that we all contribute whenever necessary and share what we think the presented slides. So today we are bonusing this presentation. So it's just a bonus. So I will not dwell that much. What I would request us to do is to go back to our previous session on breakthrough pain, on neuropathic pain. Actually, you can go to IE Course Pack. You can have access to all those slides. You are free to use them even for presenting to your colleagues or use them as a reference. So they are available for use. So today we'll be looking at pain management and then the breakthrough pain bonanza. I have a big challenge with my projector here. I don't know if you can see the slides on your side. Is there anyone who can see the slides? Do you see my slides?
Yes, we can see slides.
Okay, thank you so much, Simpiwe. Okay. So last time we defined what is breakthrough pain. So breakthrough pain can be defined as a transient increase in pain of moderate to severe intensity, which occurs against a background of persistent pain of mild to moderate intensity that has been controlled. So what normally this, when you look at our palliative care guidelines, we are saying that this is the pain that occurs in the midst of a well-controlled background pain. For example, today the patient has pain diagnosed with stroke, arthritis, has diabetes mellitus, has HIV, is TB, is whatever life-limiting or threatening condition. Then you have this patient having a certain type of pain, and then the intensity, the pain was 5 or less. And then when this patient was having this 5 or less on the intensity of the score, all of a sudden, taking this regimen or this type of medication, it was well controlled. Then all of a sudden, there are some balloons that are coming, showing some that the pain now is escalating at some point, showing more than what we expected, maybe growing up to 6 or 7. So that's the pain we're talking about. So it shoots up and down in the background pain. So we knew you are taking 5 milligrams of morphine, or you are taking tramadol 400 milligrams in a day. It means you are taking 100 4 times a day, maybe, or 3 times, or 50 milligrams. But now you are having these types of pain that are now coming up to disturb the patient. All of a sudden, you are experiencing such a situation. Then we say that type of pain, it's pain that breaks through a pain that was well controlled. What you need to know is that for you to say the patient is experiencing that breakthrough pain, the background pain must be moderate to mild or less than 5 on the score. So once you have achieved a moderate to mild pain in your management of the pain, then all of a sudden the patient is experiencing some episode of high pain. Then we call that one a breakthrough pain. So from Diana's presentation, he made it clear that breakthrough pain comes into 3 folds. Which one is end of dose failure pain, which is indicative that the dose of the long-term analgesia that you are prescribing is no longer effective. For example, we said when we're describing prescription of opioids especially, we said that when we are prescribing an opioid, we start with the short-acting opioid so we can identify the optimum dose to control the pain to moderate. Then we then convert from that short opioid to a long-term opioid. Then when we are prescribing that short long-term opioid, then it will be covered. Most of the time in our country, we are using morphine. It will cover the patient on a 12-hour clock in terms of 2 doses, one for 12 hours, another one for 12 hours. Then once you have end dose failure, you will find that the patient is taking 10 milligrams of MST, which is our tablet morphine. But around 12 p.m. from 8, around 12 p.m. before the next dose, which will be 8 p.m. maybe in the evening, your patient is already experiencing some pain. Then we are saying there down, this is end of dose failure before even especially this one happens around end of dose. We found that 2 hours before the next dose, the patient is already beginning to experience pain. If I will be drawing a graph, you will find that the pain will go up, like my case is going, and then towards the hours, then the pain will be going down. And then when the curve of the pain, the amount of the analgesia in the blood goes down, then you find that then the patient will begin to experience pain. So then we are also saying that one is end of dose failure. So we need to adjust our dose so we can see how best we can manage that one. Then incident dose failure, that one was termed to be pain. That happens when you are performing a certain activity. So we have a predictable and non-predictable. For example, I'm going to be changing a patient's pain, or I will be performing wound dressing. So when we are performing wound dressing, we are sure that then our patient will have pain. So then we will prepare a certain intervention to maintain that pain. But there is also an incident pain that cannot be predicted. For example, a patient was doing ADLs or was performing ILDLs efficiently without a problem, but then today he tries to stand up from the wheelchair and then he experienced pain. That one is unpredictable. We were not aware it would happen, so also tell the time. Then idiopathic pain is one of the difficult pain to manage because it is not clear what really caused it. So, but it is there, but we are not sure what exactly caused it. So that's what we are saying, it's pain. So all of a sudden, the patient is going that way. So I've prepared this flow chart that can help us when we are trying to manage breakthrough pain in our facilities. Or actually with pain, but this one is very good when you're managing breakthrough pain because it helps you to follow certain routes and see when to refer and how to manage. So there's just one thing I forgot to put in this allographically, but I would say it. So what the first step is that you treat the background persistent pain with using the standards that you have set, using the guidelines. You prescribe your breakthrough pain dose. Around the clock dose, then you are giving your patient medication to manage. That's what we need to do. And then, as you are doing that, you also, when the breakthrough pain comes up and your patient, once the patient experiences this breakthrough pain, the first thing you need to do also is always rule out the treatable cause of the pain. So because there are issues that you'll find that these are maybe behavior related, or they are based on how the patient is taking the medication. They are based on the efficacy of the medication itself. So you need to rule out what could be the cause of it. Some of the issues are just education. You educate the patient to avoid certain behaviors. Let me make an example. Now it's summer. You will find that we have people who have issues of back pain. And then because they are taking certain medications, you will find that then now they are aggressive on how they provide care, how they do their ADLs, maybe their activities. So maybe patient was doing cultivation in the field, and he went to the field, and the manner in which he is handling the tools is not good for the backbone. And then you will find that the patient will coming with this type of pain and stuff. So then you will understand when you are eliminating the cause, then you will find that this is the cause. Sometimes the cause can be due to a metastatic that is happening, or the progression of that cancer, or the progress of the arthritis. So then you will know, can you reverse the situation or not? That one will help you to know what interventions you can put complementary to that pain that is there, other than to bombard maybe the patient with drugs that you know it cannot be reversed. Sometimes it's just psychogenic pain. The patient had a depression, there was a funeral at home, he has lost a certain member, and then now all of a sudden he's experiencing. So that one helps you to identify this is incident. Is this end of dose failure? Is this idiopathic pain? So it helps us to identify that one. Then once you have done that, then you look at your your around-the-clock analgesia for background pain, and then you continue prescribe your PRN analgesia for breakthrough pain. So once you know then now, these are the problems that are causing the breakthrough pain, you will then review your analgesia. It means you're around the clock analgesia, which means it's your dose that you have been using for the background pain, and then you prescribe your PRN. What we normally recommend is that always when you are prescribing an around the clock analgesia, always prepare or prescribe a PRN analgesia for breakthrough pain. Anticipate that there will be a breakthrough pain, and then educate the patient on how to take the breakthrough pain dose. Let me make an example. You are prescribing an MST tablet of 15 milligrams or 20 milligrams to be taken BD, you see? Or then what you are going to do then, it means your patient is going to take 40 milligrams in a day of morphine. Then you will prescribe either 5 or 10% of that breakthrough for breakthrough pain of the liquid now, so that the patient will know that once he experiences breakthrough, this is the dose he will take. So the calculation of your liquid will be a 5% of your daily dose of the MST. Then you educate the patient on how to take the medication and manage the pain should there be a breakthrough pain. Then from there, you move to Eswatini, there's a problem here. Yeah. Then from there, you move to a reassessment of the pain and outcomes. So every time when you are going to do the reassessment of the pain outcomes, it is very important that once you have prescribed a breakthrough pain analgesia, you help the patients to keep or to use a diary. I've seen it during my practice in the home-based unit, or during the practice, or even today when I've gone out to meet a patient. I encourage my clients that they have a booklet, a small one, where whenever they will take an extra dose of what was prescribed by the physician in the hospital, they then write it down and call the nurse for management. The diary will help you to know how many times the patient has been taking the breakthrough dose and what was the pain score by then, so that it will help you. And also what you use also here is that you also strengthen your non-pharmacological options. Now you have prescribed your breakthrough dose and you have helped the patient to take it. Also emphasize on the non-pharmacologicals, because we wish our patient could not experience breakthrough pain. So we want them to go back to the under or the background pain. So you also look at these two models or interventions that use your patient's diary to monitor this patient, and also emphasize and educate the patient on non-pharmacological options. If the patient cannot read and write, it's very important to know the family status and the caregiver, so you can encourage them to keep a diary of how the patient is taking the medication, because we will end up overdosing the patient, and then the patient will be overdosed and they will say they cannot take the medication because feel overdosed. So then routinely, you will continue assess and reassess the patient outcomes. Normally here, you look at the target or the goal that you have with the patient. So you can reassess your patient a week or so after you've prescribed, or you can link the patient with institutions like a Hospice at home, or Good Shepherd home-based units. Those institutions, they do go to home and monitor the patient, or you can embark on telemedicine, which we call telehome visit. You call your patient to do some review, reassessment, and see how is the patient coping with the breakthrough pain, with the breakthrough dose, together with the around-the-clock medication. That one will help you to know if it is effective or not, and if the patient is complying with the diary and the non-pharmacological options that we have agreed on with the patient. And then that's what we have, once we are doing that, that one must be done consistently. Then you go down and do, so if you are doing your reassessment, if the analgesia is working very well, the baseline patient pain and the breakthrough pain will remain unchanged. You will find that the patient patient pain is not increasing. It's better go down or remain constant. So once your baseline pain is not increasing or it remains the same, it means you are achieving your goals in terms of managing the breakthrough pain. And an effective analgesia or plan or interventions will result to then you modifying your treatment. So this is what we are saying in our guidelines if you review them. Then there is a formula there that you will use to calculate for another dose that you will give to your patient to manage them down the established persistent or baseline pain or the background pain, because now we have established, because one of the reasons that may lead to breakthrough pain, now we have modified if there are predictable incidents or causes, so now we have managed them. If then it was end of dose failure, now we have understand how much the patient needs in a day to ensure that he remains with moderate to mild pain. So if then now we have done that, we are saying that then you have established the maximum or the optimum dosage of the medication that might be required in a day. How then do you come up with that one? You add your baseline daily dose for the day plus the total number of breakthrough pain doses that the patient took. So if the patient took 10 milligrams in a day of morphine as a baseline, and then breakthrough doses, they were equals to 8 milligrams. I'm making an example. When you total all your breakthrough doses, they were equals to 8 milligrams. Then what you're going to do then, you will add your 10 milligram, which is your baseline or around the clock dose, plus your breakthrough pain doses, which are 8 milligrams. Then when you divide that by 6 times in a day, so that you will return back to your 8-hourly dose. If you will not there, that's the only way to titrate your own your opioids, especially effectively and nicely. So you will have an increased dose, which will now become your baseline or your around the clock dose. I don't know if I'm making clear. If my patient was taking an around the clock dose of 10 milligrams in a day, and then has now taken a breakthrough doses that equals to 8 milligrams in a day, then I will add these 2 doses, and then I will divide by 6. So then I will have a dose that will be equivalent for a dose that will be taken 4 hourly again as a baseline dose. Then I will redo assessment. So if then that calculated dose has been made and you are successful to manage the patient's pain, your patient will have an effective analgesia that will increase the patient's function. If then you are not successful, you will then need to refer to a pain specialist for a dose limiting toxicity. Sometimes you'll find that while you were titrating your dose, here I missed to put unsuccessful for when you are going to the right, and then successful when you are going to the left. So I will edit before I send it to you again. So when you go to the left after modification to 1 dose, because we are trying by all means to reduce the amount of dose a patient has to take, or we are reducing polypharmacy. So once now we have established our dose, now we know that our patient is responding very well. You will see by effective analgesia, by increase in patient function. But then if it's not as successful, the best way is to refer to a pain specialist, because normally there you'll find that If especially then there are aberrant drug behaviors and those limiting toxicities, then you are finding that your patient is now beginning to show some symptoms that there's some toxicity as you are escalating the dose. You refer so that the patient can be managed very well. But most of the cases, if all this was done very well, the assessment of the patient outcomes and the titration was done very well, you'll find that your patient will respond very well and they will have improved function and have an effective dose. And remember that an effective dose or an effective analgesic dose is the one that helps the patient to manage his or her own pain. And then this is what we need to routinely do, which is continue to reassess and reassess every time. So you use ongoing use of the patient's diary. Remember that you are not staying with the patient every day in the hospital. They come and go, they come and go. Another tool you can use to trace if they are taking the medication very well, educate them to do a diary where they can write the time they took the medication and the dose they take, and the type and the amount of pain they experience. So you have the severity of the pain, you have the time, you have the amount of dose taken. Then when they come to hospital for refill of that medication, you review the diary and you do the interview. They tell you, you assess what they are saying and what they've written down. And then that way you will be able to see if the medication is working well for you. And then what you normally then need to do, I've said that you rule out the treatable causes of any pain. And then there's what we call the 5 A's in pain assessment. So when we do our activities of daily living, we talk of our ADS and ILDS. And then we talk of adverse effects or side effects of the medication. You check if the patient is experiencing any side effects or any challenges. And then look at aberrant drug taking behaviors. We have been treating a topic on managing chronic pain and management assessment and managing risk of opioid use disorders and misuse. So that then you will see the aberrant behaviors and diversions that this patient is really now misusing the opioids, and that way you will be able to identify the root cause of that. And then also you look at the affect. You know, sometimes these drugs, they put patients in depression, and you look at if they are still coping very well with the drug. So that's what we do when we are looking at these opioids. So then I just need to put you again. If you will notice, most of the sessions we've been going through, we are talking about assessment, communication, It's because this is the most pillar that we need to go through as clinicians when we are managing these patients. So here I'm just listing these ones. We have shared them before, that when you are doing a comprehensive pain assessment, the first thing that we need to understand as clinicians is that we cannot do everything on our own. We need to form an IDT, work as a team, especially when we are in a clinic. We need to have different skills and approaching ourselves. I am responsible, or I'm good in advanced directives, I'm good in physical management, I'm good in psychological care, I'm good in family assessment. So we need all these people, the social workers, psychologists, everybody together when we are assessing for pain. So we need to elicit the characteristics of patient's pain and pain symptom or symptom. Whenever you are doing an assessment, elicit the characteristics of the problem. So the onset, the quality, severity, provoking and relieving factors and location. You know, sometimes I say an assessment, a pain assessment done by someone who has attended our sessions, his documentation comes clear and more details. So when he says the patient is pain, he's more clear. When is the pain, onset, quality, severity, provoking and relieving factors, location, and type of medication that is working on that one. And then also assess the functionality history, the impact of functionality on functionality and quality of life. This one, most of the time, you get it from the patient. How is the pain affecting the patient functionality? How is this symptom that I'm facing affecting the patient's quality of life? And normally the quality of life is defined by the patient. So the instruments of activity of daily living are these things that the patient is doing to manage his own life, other than the ADAs that are basic, like eating, bathing, you saw those things, ambulatory, those are activities of daily living. So your access has this effect. You find that some patients, because of pain and other symptoms, they end up having memory loss. They cannot remember where was their bank account, what is their bank account, where is their card. They don't remember who their sons are. So then you know, this pain is affecting this patient so much. And also we assess for meaning of distressing symptoms, especially pain. What is the meaning of this pain to you? This one will lead to even to spirituality assessment. One will say to you, you know, this is a curse from God. I cannot sleep the whole night because it was paining and hitting me, and I've seen it. So we are saying, also find out the meaning of this problem. What is it? And it will help you when you are managing it. And the patient's goals of care. We normally miss this one. We push our patients to what we think they want, not what they need. And that's where our difference in goals of care comes. And then they will say, today you are seeing Nessie Tandazi. That one is a failure, you know. I've been seeing her many times. She cannot control my pain. It's because your goals of care and the patient's goals of care couldn't be aligned. So when you're aligning the goals, patient will say, I want my pain to be finished. And when you know this is a metastatic cancer and without curative therapy anymore. And then that's an unrealistic goal. So your patient's goals, you need to then help them channel their goals to be smart so they can adhere to the medication or interventions you have suggested and agreed on together. So when they've clear goals, then now you will be able to manage their pain. And then we are always saying review drug and non-drug therapies. So this one, it includes response to prior treatment and level of burden, as we've been sharing in that slide, that when we are managing breakthrough pain or pain naturally, reassess and reassess, find out what was prescribed and how has effectively been on managing the pain. And also, please, let's always assess for a level of burden, especially pharmacological burden of drugs, because polypharmacy is killing most of the patients. You know, the patient is NCD drugs, the patient is on ART, the patient maybe is on TB, the patient is on hypertension. You know, you'll find patients in, we say combo. You know, Tinamaso is a tenga picking pain as a spam. We buy the combo about they have cancer, hypertension, diabetes, HIV. You know, they have a lot of drugs. And then when we are prescribing your drugs, then you need to monitor also the level of burden. How is it, even including your non-pharmacological exercise, do this, look at the capability of the patient. Is he able to cope with what was prescribed? If not, let's discuss how we can manage it. That's why we are saying, even if they are approaching the end of life, some drugs need to be dropped off. The priority should be comfort. So we need to look at around those issues. And then ascertain the effectiveness of the treatment, we need to look, is it still working? So we can even advocate and advise the physicians to see if this medication is still working. I haven't seen hydromorphine in the country. Yet hydromorphine is very good for people with on dialysis or kidney problems. So you see that you'll find that the morphine is no longer working for this person who's undergoing dialysis. And now when we are weighing the effectiveness of the drug is not working. So we need to do. But we will look closer to this effectiveness when we are doing with the end of life care. You know, there's a word that comes in when we are reviewing this, when it comes to deciding the withdrawal and withholding of treatment. You know, there's a fight between the clinicians, the doctor, and the patient. When we are saying now, or family, we are now withholding this certain drug. So, and then what will become? Some will think you are killing or not, but we are looking at the effectiveness of the treatment, and we need to discuss together and determine the signs of opioid abuse and diversions. You will find that these patients were high-risk patients. They were using alcohol, they have a history of taking tobacco, insangu, they have a history in opioid or substance use disorder, or they are using alcohol or this, or they have a history of abusing certain substances, including alcohol and other drugs. So we need to always, every time you have a clinical or an outpatient visit, or you have a patient who is admitted, go check your files if they do provide the screening of risk for opioid use disorder, because we need to know those who are at high risk and those who are at low risk, so we can know how to monitor them, and that one will determine your frequency of refills. So if you have not done the risk assessment, you will be in trouble. You will find that even if they come for breakthrough pain, you cannot tell if it is because of opioid use disorder or diversions or misuse. So it's good to determine that in your documentations, review them so it can cover that one there. If then there are tools you need, we can go and see. There are many tools we can supply you to do that in the hospital setup, and then you will be able to capture those clients who are able to and detect opioid use or misuse as early as possible. Another thing that we normally have no time for when we are doing comprehensive assessment, it's examination of the patient and review of previous data. This one is very critical. We also emphasize with our team here at Hospice that when they are doing their home visit, they have a prescription book where they have to document their care for that day for the patient. So that when the patient goes to Manzini Hospital, goes to RFM, goes to Babane, or is seen by any of the Ministry of Health partners in the community, they will be able to see if the patient is receiving any care or anything from any person. So the documentation part of it needs to be there. So you can know you were given tramadol at a hospice last week, and you were given so much doses, and you are not supposed to have finished it today. Then you are able to detect the misuse and stuff as early as possible. You were prescribed an opioid of this far at Manzini Hospital, but in 2 weeks you have finished it. And this is the prescription. Then you are able to call the prescribers and verify the type of patient. Then you will find that the patient's healthy and effectiveness. You cannot repeat one and the same thing. I've seen in facility by a patient, there will be no assessment. There will be just represcription without the review of what exactly, how is the patient responding. Let me make an example. A patient is on ART, and is on hypertension treatment. You will find a patient on HCTZ with an unstable BP. And when the patient goes to a clinic or a hospital, the clinician will just only prescribe without reviewing the effect. How is the patient responding? How is the patient taking? So it's very critical on documenting. When we are documenting, please document both pharmacological options or interventions and pharmacological, so that it can be managed if the patient is adhering to both treatment. I usually borrow the art department language of saying, any patient who is not adhering to treatment must be quickly moved to SWAC. So we need to do it even in palliative care. Any patient who is not adhering very well, we need to put into SWAC so we can see what exactly is the problem. And then this one, when we have done the examination and review of the document, it helps to guide the care plan and decision making. You are going to make an informed decision, and believe me or not, your patient will improve in one way or the other. And also it will help you determine the issues of the problem. What exactly is causing this problem? And you will be able to address the problem than the symptom. So you will be able to do that. And this one, I will say, doing examination provide support to ensure that our interventions are efficient and effective. When we say efficient, they are cheap and effective. So that's what we are saying to do here. And then this is a guide, it's a protocol that can help us to do our management in whatever pain level that we are. We can use this protocol to do that, which is one, we need to ensure that step one, we complete the pain assessment. Always, before you think of prescribing any drug, finish the pain assessment. And then also, we then need to you match the appropriate drug to the pain type. I usually put here, match the appropriate intervention to the pain type. The pain types, we say there are many. We have the holistic pain, physical, psychological, emotional, spiritual, social aspects of pain, or cultural aspects of pain. We have physiologic, we have neuropathic, somatic and visceral pain. We have breakthrough pain. We have all this. So we need to describe the type of pain unto the last note, so you will know exactly. Let me make an example. If a patient has breakthrough pain or has pain that is neuropathic, prescribing Panadol alone might not be the best way. When we are looking at the levels or the class, the stages of managing a breakthrough pain, one of the first things is that you might need amitriptyline, the base, to manage neuropathic pain. Then you go up to your step 2 drugs, which is the weak opioids. Then you go to your strong opioids, but your base will remain be the acute, which might be gabapentin or these neuropathy or these anticonvulsants. So if then you have not ascertained the type of pain, you will continually give people Diaclo and stuff. And if a patient has a bone pain and you have not put maybe a prednisone or Diaclo there, or an NSAID, you might not achieve your effect. So knowing exactly the type of pain will help you to do that. If a patient has visceral pain and has abdominal colic or cramping, and then you are not prescribing Scopex for that pain, you might not achieve your goal, and you'll find that the patient will not be responding well to your treatment. So knowing all these things help us to do that. And then you consider the potential and risk of the side effects of the treatment, whether you are doing breakthrough pain management or whatever. Always consider the risk. You cannot prescribe high doses, especially we are saying when we are prescribing Panadol and a liver person. So you know this one will not work good for this patient. When we are prescribing for people with kidney failure, then you are putting more that you need to know, and then you need to balance between the needed outcomes and the side effects, and then you agree on what exactly needs to be done, and then you assess the safest route of delivery, how best the patient will take the medication. In the field, sometimes we find the patient given MST morphine, and he has a orofacial cancer. This patient has a difficulty of swallowing, and you are prescribing tablets. Really, how is the patient going to take the drug? So we need to review all these things so that we can see how best the patient can take the medication. And then you consider who will administer the patient. You will find a dog at home with a big box of morphine, saying this medication, they say is for abdominal pain, or it's for my stomach. Once my stomach is okay, I will stop taking it. So if we know who's going to take it, and are they educated on how to take it and how to store it, and then we can continue, then determine where the patient will be able to find it in a local area. This one addresses the issue of structural part of palliative care. That whenever you are diagnosing a patient or you have a patient in RFM, please, once you have prescribed anything for the patient, link the patient with resources at the community so that you limit the financial strain on the patient when possible as you can. So that the patient, if a patient is from Jogolago, then I need to refer the patient to Jogolago. So she or he can refer next to Jogolago. If there are no facilities where the patient is located, then I can link with home base. So your patient will suffer less on the social, psychological, and then you look at the assess the cultural, spiritual, social context to the pain. Thank you so much, team. In my summary, I will say that all pain can be controlled, and always ask patient about pain experience. They will never tell you, but you need to ask them, always ask them if they feel any pain. And then they will be able to respond. And the majority of our patients with life-limiting and threatening conditions, they indeed suffer pain. They might suffer physical, may not suffer physical, but they are going psychologically, emotional, and spiritual pain, including us as clinicians in our wellness department. Tell them to ask us if we are experiencing pain. Some of us are suffering from financial pain, there's no pay increase. Some of us are suffering social pain, family disruptions. Some of us are suffering political pain. We lost elections. You know, we are going in tremendous pain, but nobody is asking us. So let's them ask. So let's ask them so we could also be asked. And then let's treat the pain. All pain, manage the pain as possible as you can. If you don't have the resources, outsource and refer, link the patient, and always ensure that the center of your management is the patient. Thank you so much for this. This was our bonanza for neuropathic and pain management for today. I thank you. Maybe for this time, I will give opportunity for you colleagues if you have any addition or questions. Yes, colleagues, anyone who wants to add, otherwise today we're just summarizing this one. Yes, so that then we will move to our case presentation. Anyone who wants to say something from the presentation? I was just reminding us so that we combine all the other things we have covered in the previous slides. I hope the silence meant everything was looking good. I don't know, I'm assuming. I can see some posts here. I don't know. Thanks so much for Mr. Dlamini Simpiwe. He's saying that thanks for such a wonderful present. I have learned that for us to proper care, to do a proper care, we need to assess and utilize our findings from the assessment to treat and refrain from refill, but assess and act according to the findings. Thank you so much, Mr. Dlamini. Actually, I don't know how we can embrace this clinical practice that let's assess and plan and intervene. Let's assess, let's plan, intervene, reassess, plan, intervene. If we cannot do it, we link. That's all what we need to do. Thank you so much, Mr. Dlamini. Anyone who wants to comment? I want us now to share our understanding and discussion in this scenario that I will share with you now. There's an interesting scenario here. I would like us to brainstorm on it. I don't know if I'm leaving someone behind, colleagues. Another thing I want to say, colleagues, is that in palliative care, we recommend and encourage that we practice or we provide our care in an IDT, which means it's an interdisciplinary. Let's be pioneers. Let's market palliative care wherever we are, and then see how best we can manage our patient. And always, in palliative care, we are client-centered, and we know and we understand the needs of our clients. Anyone who wants to add? From my colleagues this side, I have a great team here. You can see them. I don't know if they want to add something. Okay. I didn't saw any hand or a comment. I can see everybody's writing. Okay, there's this case that we have, colleagues. Can we share our experiences? I was hoping Cyprian would be in by now, but he's still not in. But for the purpose of us applying all palliative care principles and understanding how we can apply them, can I present this case to you, which was to be presented by Cyprian Matsenjwa. This is the situation. This is a patient with an advanced lung cancer. This patient is advanced lung cancer, and the problem here was that there were barriers that were there during the course of treatment. So was to address some barriers during the course of the treatment and develop a mutual trust. So this is what Cyprian was looking for. But today I want us to look at the situation of this patient and look how best we can attend to situations like this one. The patient has persistent cough and fatigue, especially when talking, been to clinic with no effect, eventually initiated to anti-tuberculosis for 2 weeks with no effect as well. So was taking this treatment and it was not effective. And then he did a CT scan at Mbabane and results suspected advanced lung cancer that has metastasized to the bones and the liver. And then stage 4, a lung biopsy done in South Africa in Nespread in a private surgery. So that's how far the patient went to get the lung biopsy. And then this is the situation, the complaint of the situation. This patient has been complaining of cough, fatigue, and then has difficulty when talking, and then has been to consultations in clinic, and then was initiated to TB treatment for 2 weeks. And then later he came for CT scan, which shows some suspects of lung cancer with metastasis to the bones and the liver already, and then a lung biopsy was done in South Africa in a private institution. I think you can see the scenario of what this patient has undergone already. And then when the pain assessment was done on this time, this patient was diagnosed to have visceral pain on the right side of the chest with a severe score of 8 to 10. And the patient was saying that the pain has been there 12 hours. I'm not sure what exactly the patient was saying there, but maybe he was saying the pain is there half a day. I'm not sure. But here he was supposed to test me when is the pain? When is the pain there? Maybe every time or some time at this point in time. So that's what he was supposed to put there. And then the pain is chronic, so it has been there for more than 12 weeks. And then the pain aggravating factors is sleeping on the left side, and the relieving factors is when the patient is walking, which means the patient to be okay needs to walk every time. And then the functional impact of the pain, that the patient cannot walk long distance. So now he takes short distance and then needs to sit down. And then now the patient is on opioids, is taking morphine, which is partially working to relieve the pain. So I think you can have scenarios, what could be the problem here. And then on physical assessment, the patient was wasted and pale looking, and the face was looking swollen on examination, and the patient was fully functional, conscious, and well-oriented, and he has accepted the diagnosis according to him, or which is means, and this patient is a male. So we are not sure instead of the level of depression, anxiety, and history of opioid abuse here. And then work status, this patient is a self-employed man and is a taxi driver, is a Form 2 level of education, and is a low-class person in terms of socio-economic status, is a married man, and he has no history of substance abuse or any habits that are harmful to him. And the relevant health condition is that he has a history of cancer at home, and his mother died of cancer, but they were not sure of what it was. So this patient has a history of cancer in the family, which is a first-degree relative. And according to this statement, it means that the mother was either late diagnosed or was not diagnosed, I'm not sure, but it looks he was lately diagnosed, and then they were not sure what was it, and the diagnosis was not communicated very well to them. So now they get the news maybe clearly later, or maybe the results came after the mother has passed on. And then when you look in the social part of it, this patient lives with family and wife and children. Unfortunately, here our scribe never mentioned the number of children that the men have and their age groups. The church member and close relative visit him at home, and the wife is so supportive, even financially. And this person is said to be a believer, but then we are not sure what the person believed. We are assuming he's a Christian. He goes to church, and some church members used to visit him. So he gets some little support from the church. Significant medical surgical history. He did lung biopsy in paravisceral surgery in South Africa, did 5 cycles of chemo in South Africa, as well as before his medical card got absorbed. So he had a medical aid, and then he did attend to a condition in a private setup. He did another 5 cycles of chemo in Eswatini. The regimens are stated there. And also referred to Palliative clinic for morphine. He is administering 5 milligrams BD. Now I think we can see now why it's managed partially, but we'll see. So he's taking these 5 milligrams of morphine twice a day. I'm not sure if it's MST, but I've never seen 5 milligrams of morphine MST. So maybe RFM team will help us on that area if we do 5 milligrams tablets. And then relevant past medical history, the patient has been on prednisolone, manzolone, multivitamin, Panado, and ferrous, and currently is taking acyclovir, prednisolone, amoxicillin, and morphine 10 milligrams. Oh, this one, 10 milligrams BID now, the controversy, and the Bisacodine and omeprazole. So now he's taking morphine 10 milligrams BID, and it's not clear if it is MST or the liquid one. I think we are correcting the 5 milligrams. So this one is there. So in terms of advanced care planning, the patient has no advanced care plan in place. So there's nothing prepared in terms of the uncertain future with this advanced mastectosis. When you look at the vital signs, the pulse, the BP was good, and the SPO was also good, and the respiration, and the pulse was 140, and the patient is equal 1 minute, is able to move around and do things, and able to take care of himself, and only needs the medication to continue to do activities of daily living. And when we're looking at the symptoms grade score, the pain it's moderate, and he has some mild drowsiness and a little bit poor mobility. And when you look at the FCB on laboratories, 7 millimoles, and in reference that's what is 12 to 18, it means this person was then for transfusion, and then CT scan shows that metastasis to the bones. I think he must be wanted to say the liver instead of the lungs. Then we have apologies team. And then the intervention that was proposed by this team was to admit the patient for blood transfusion and platelets, And however, the blood transfusion was withheld since client developed fever during transfusion, and then the patient was for oncology review in the morning. So this is what he has said. There's nothing that much on the interventions. May I give to team of this client what you can say? What can you say about this client? This male person with advanced cancer with finished funding in terms of finances and diagnosed metastasis and men married and have children. So, who is this? So, Yatanazil is saying that he has not seen 5 milligram. I think now then, because he also mentioned that he's taking 5 milligram, but on the situation, I just wanted to look at how best we can manage a person, a male figure with advanced care, with advanced lung cancer, who is married and have a spiritual support family with anemia. How best we can manage this patient? What things we can do to this man who has advanced care, who has advanced lung cancer? If this patient will present into a facility with this history, what best we can do? How best we can manage this patient with all what we have learned now on pain management? Yes. What do we think is missing from the data and how best we can collect it? Maybe we can start there. What do we think from the data that we have get from this presentation we think can help us do an informed intervention and that we think is missing and how best we can collect it? Yes, colleagues. Yes. I'm happy to see hands coming. What do we think we might need to comprehensively manage this patient from this patient who has advanced care, who has advanced lung cancer, has done 5 cycles of chemo and repeated 5 cycles in the country again, now has been in hospital for transfusion of blood, but then developed some side effects and it was withdrawn, and then we have the family, we have the children, we have the patient, we have the church, we have the clinical team. What data we can need or how best we can manage? What do we think we can advise Cyprian and team from Babane to do for this patient while we are here? I'm hoping you will be able to see from the video once we upload it. What advice can we give to him? I hope everybody's got the discussion question. Any comments, Tim? Nompumelelo, how are you? Who has left? So many people are gone. Is it me who is disconnected? Okay. Yes, anyone who wants to say something? Nompumelelo, I've lost him again. I've lost her. Zifle's team. If this could be your case at RFM, what could be your suggestions or comment? What can be your suggestions and comment for this patient in terms of pain management is concerned or management or any questions or comment you can have or you are not sure what exactly can be done? Yes, Tandazile.
Good afternoon, Tim.
Yes.
Yeah, it may be a bit difficult dealing with it this way because we may need to keep referring to your presentation, but it's not there anymore. But I'm thinking this man here, he has been through a lot, like everything happened so fast in a very short space of time. He thought it was something else, but then from that he discovered it's actually, they tried TB treatment, like in a very short space of time. They discovered there is a possibility it's not TB, it could be something else. But then also in terms of accurately diagnosing, then he had to dig deep into his medical aid. Fortunately, they managed to do a biopsy, which actually confirmed that it is actually cancer with the origin from the lung. And unfortunately for him, by the time he discovered, it was already advanced cancer. He tried whatever he tried with his medical aid and it got exhausted. So now we are having this somebody who was living his life in that way, having a medical aid that could actually cover his medical bills and everything, but it's exhausted. So now he's lying probably in a public hospital, which is something new for him. So I'm thinking more than anything for this one, I would start by establishing his feelings about his whole journey of starting from when he started getting ill and the whole process until he discovered that actually it is lung cancer and it is advanced. It is advanced at this stage. Yes, there will be so many social issues. Obviously, probably he was, because he's the man. He's probably the breadwinner. Yes, he may have the support from the wife and other family members, but it doesn't take away the responsibility that as a man he has to provide. So to some extent, we will need to actually establish to what extent the burden is in as far as his social responsibilities are. He's a father. We know he has kids. Also, he's a husband to a wife who has needs, and his sexuality probably could be at this stage, it could be tempered with, because at some point we said he experiences severe pain, and there's a lot that comes with it. Anyway, I may not get into it like in that way, but there is a lot that comes with it, and actually activities may actually exacerbate or make the pain and actually temper with his capacity to perform some activities. So his sexuality as well could be affected. His responsibility as a husband could be affected. His responsibility as a father could be affected. As a member of the community could be affected to a certain extent. Your spirituality, you actually narrated that one. I won't get much into it, but there's just a lot going on. So at this point, I would probably want to know how he feels about this whole thing, and how best can we actually assist in as far as his feelings are concerned, and what he thinks we can do best for him. Yes, there is also the component, the physical aspect of it. We do realize that he has this visceral pain, and the score, if I remember very well, it was around 8 out of 10, which is severe pain. Then we will need to actually deal with the pain, considering the 5 milligrams. It's actually our entry point of management in as far as pain is concerned. And also, we are only seeing the strong opioid. I didn't see anything like your step 1 drugs or any adjuvants if we feel that there's need for adjuvants. So we need to establish the right dose for him and the frequency in terms of how many times a day he has to take, because if it's the liquid morphine, then it has to be every 4 hours. Obviously, we will have to probably do it breakthrough pain at some point if we are not able to effectively control. But starting point, we should have like at least your 4 hourly. And I think the entry level of 2.5 mils or 2.5 mils or 5 milligrams could be too low for someone who is actually at around 8 out of 10. I think in a nutshell, that would be it. I'm not sure, because for now, I don't think I could be able to cover everything. I may forget some of the things. I think if we were to have the presentation and go through them one by one, I think, but for now, that should be my submission.
Thank you so much, Thandazile, for sharing that. Actually, you are showing good. There's one thing that I've seen common within our clients, but I'm sure not from you guys who have been in palliative care for some time in these trainings too. You find that they will write morphine, whatever dose, then they will write 6 hourly, or they will write 3 times a day or 4 times a day. We need to correct that. Every time we get more, there's no morphine that can be provided like that unless there's a certain issue that is being managed. Because pain is there, especially when it's cancer. So we find that maybe the patient is experiencing that patient pain because he's taking the 10 milligram 3 times a day. If it's the MST or the liquid, we cannot take it 3 times. If it's MST, it's only 2 times. If it's the liquid, it's 4 hours. So we see that's the challenge that we might see there. Yeah, I don't know what else, who else can say something, but Tanazi also mentioned that he can look around the issues of the burden of the disease on the patient. And I would suggest also on the wife, who is now the breadwinner. Who can add from Thandazile's contribution to such a patient? Mind you, he has respiratory distress already. He cannot take his steps without lack of breath or air, so he needs a lot of attention. What can he do? She also touched on sexuality issues. We can experience that, and we are not sure of the wife, what is happening. Colleagues? Anyone who might need to add something? Yes, I see Zinhle. Do you want to add something for this case? And this is a 42-year-old man. Anyone wants to add? Mhlanga, you were lost when I was looking for you. I can see you are connecting somewhere. Okay. Nompumele is trying to connect colleagues. A few minutes. Yes. Simpiwe, do you have something to say about this case, patient? A 42-year man with a difficulty in breathing, with advanced lung cancer, finished medical aid, you know, severe pain, visceral pain, taking morphine 3 times a day. Yes, Mhlanga, do you have to say something? Okay. You are welcome, Simpiwe. Okay, colleagues, for the sake of time, What I will also add in these situations, I think we will unpack it in, we will look at these areas maybe in presentations that will come. One of the issues that we look around here is to address the physical symptoms that are presenting. One, which is pain, and the second one, which is the breathing issue. And then we have to address this, the pain and the issue on the physical area. Another thing that I can say that I don't know if you have met these people, because now we have the chemo there. Most of the clients with lung cancer, you find that for a long time, they have been given TB treatment. And then later, or if they were not given TB treatment, they have been taking cough or upper respiratory treatment over the counter or from facilities. And then later to be told it's cancer and it's advanced stage. This one comes with a big burden of pain, psychologically, emotionally, spiritually, and financially on the families. In the country, sometimes, you know, you will find that there's a client who comes for cancer screening, and then later it develops a certain type of cancer, and then they will gain anger and say, I've been screening, why me now? So one of the other issues then from the physical symptoms that we have seen is to then look around the issues of psychological one. In psychology, we look at the depression, the anxiety, coping mechanism, grief, you know, because there's a lot of grief that they go through after they've lost their lives, before even they die. We look at anxiety, grief, and we look at depression. We look at coping strategies on the situation now, because they sometimes then develop maladaptive coping mechanisms. And then so we need to align those. When I mean the client here, I mean even the family, we need to look at those issues. And then the social issues, looking at the support, financial, sexuality, family system, how interacted it is, the dynamics, you know, access to resources, financials, food, everything that has to do with this. If the person was working, you know, what this means to them culturally, and how are they coping with it. So we have to look around those issues. So the assessment look a little bit bulky, but we need to do it because it helps you in your management. So you are able to go straight to the real problem and then address it as soon as possible. Then spiritually, we are happy the church is coming. There's a model, we will cover it in the next coming presentations in other batches, which will include the hope model. We need to use that model to see, to detect any spiritual distress, because the church might be coming to see the person, but the person is undergoing some serious issues, including the children and the family. We have to have that barometer check or screen them through what are they going through. Two, are the children aware of what is their father going through and how is it affecting them? So that we then, you know, we need a psychologist, we need social workers, what interventions are needed. So the total pain concept is well managed. So I think that's mark the end of our session today. So colleagues, may we request, I see some comment here from Simpiwe. Yes, Simpiwe is saying I can prepare that at 2 weeks on ATTs through assessment. They investigate beyond TB because usually we evaluate ATTs after 2 months. I see another question from Simpiwe saying, how can we improve how can we improve our problem analysis on this? Because we assess but unable to make the right decisions. I can say, Mr. Lamine, that most of the time interdisciplinary approach will help us, because you'll find that we cannot maybe here now determine what needs to be done, especially on the diagnosis and treatment of TB. I know in the guidelines, national cancer guidelines, it's stated clear that any patient who has persistent cough or symptoms of TB must also be screened for a lung cancer. Most of the situation is just put the patient on CT scan so you can quickly see what is the problem is. And then also is that when we educate our people that they must quickly come for if you have a chest or a thoracic problem, come as quickly as possible, or respiratory problem, come as quickly as possible for assessment and diagnosis as early as possible. Otherwise, this is one of the times I've seen that most of the clients, they delay. But as a team, then once we have this patient, it's very good that if in a facility, let's establish an IDT when a patient presents, each and every area is assessed, or if one person has done the assessment, we have a meeting at some point to discuss the patients that we have so that we can be able to address any challenges that are coming as quickly as possible. Otherwise, this is a problem. You will only identify it when all has happened and you are the client. So the guidelines are there. So I think we need to adhere to those guidelines. Thank you so much, Mr. Dlamini, for that. So I was mentioning that our next session will be on 22 November. What we are going to do in this session, one will be introducing the other batch that will be coming. We request that our next batch will be covering symptoms that are there in the common symptoms management in palliative care. We request you colleagues to forward any symptoms that you wish we could cover in that next series that we will start. And another thing that we will do is that next session, when it ends, we will share with you a post-session test, which is a multiple choice test. You will just fill it online, and then you submit your test to us. And then from there, we will be able to share with you your attendance certificates. And then we request that we know some people have regulated. So to be fair, when we calculated the hours that are the sessions that we have had, we will look at those people who have managed to attend more than 50% of the sessions. So we'll calculate that those ones will have access to the attendance certificate for this batch. But for the next batch, we are hoping to start it very fresh with everyone on board. So we will be able to also get certificates. So every batch that we will have a certificate of attendance on it from IECO. And then another thing we are requesting that come prepared with your topics and questions. And we kindly request you to go back to our resources or videos in Eswatini YouTube channel. Watch those videos so you can compile your own questions. So next week, it's a question and answer session. Bring your questions. If you have questions concerning patients that you have met in your facility, bring them in for discussion. If you have any question concerning the batch we've covered, bring those questions next session on the 22nd of November, 22 November, same time. We will be summarizing everything we've covered concerning non-pharmacological and pharmacological pain management. Bring any question you think we need to address concerning pain. And if there is a symptom that you feel like we need to cover during this session, also come with it. You can share it via my WhatsApp. We will then present it here. We are preparing for another batch to start early December and then continue very well next year. So wish you all the best as you come for the next session, as we are combining everything together. For anything that you have a question of or anything that you want to ask, we'll be summarizing that. But most importantly, if you have any topic concerning symptom control, we'll be summarizing our physical domain in palliative care. Then we'll then be able to move to a psychological and spiritual and other domains. So we request that you share any symptom with me in my WhatsApp, or you can bring it next week in the session, in the other session. You can come prepare with it. We will share it here on chat while we'll be discussing. Any problem that we have met in the field while we're trying to practice these issues that have been discussed in pain in the previous presentations, come with them so that we can see how we can best address them together. Thank you so much. Anyone with a question for that? Anyone with a question of what we have shared already? Thank you so much. You can go to our YouTube channel. It's as good as 3:30. You will have access to our YouTube channel. All videos that we have covered in this session, they will be available there. Have a good day, team. Let's meet on the 22 November when we will be doing a summary of all what we have done under pain, and then address any concerns or questions or any challenges we have met in your facility or in your practice. Any question that has to do with pain, we'll be addressing them on the 22nd of November. Thank you. Come ready to also finish the online test, which will be available after the session via your emails. And then you will get your certificates 2 days later after Plan 22. Thank you so much. For anyone who wants to do registration with Nursing Council who have been with our session, can come. Please come so that we can check your attendance and verify your hours. We will stamp it for you and sign your logbook for you. We are open for that. So come to us. If you will need that, call me and arrange it for that time so I can arrange and see how many hours you have, and then you will be able to sign it for you. Thank you so much, team. Let's meet on on 22 November. Bye-bye.
Thank you. Bye.
Bye-bye, 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 colleagues.